Thank you everyone for coming. We have very interesting topic today, but we should discuss in small details, I think. We have absolutely excellent speaker, Professor Alessandro Genazzani, and we have quite good amount of listeners. Let's start. Thank you.
Thank you, Ineta. Ladies and gentlemen, it's my pleasure to speak about what happened when we have an estrogen decline and this effect on hot flushes, mood, and vaginal atrophy, and then to speak about the science, the DT56A, and our ability to treat women. These are my disclosure, and this is my presentation will be organized in that way. We will speak about first on estrogen decline and its impact on female health aging. As you can see here, the aging of the individual is characterized by a progressive evolution of hormonal milieu. From the moment of the birth, we will rise till the adolescence, then the life of the woman is characterized by the growing presence of estrogen, they have very profound effect on any organ, on any tissues of the woman. But then we have also the aging process. And as you know, in premenopause and in perimenopause, this is a time characterized by wide oscillation of gonadal steroids, who characterize the difference that we have in the changes in the cycle duration, which are associated to different concentration of estrogen and progesterone. And this very oscillatory characteristic of the hormonal peripheral concentration changed later on to a stability with depleted steroid, depleted estrogen, depleted progesterone, and higher gonadotropin. This make that we have since the moment of the menopause, we have a huge series of symptoms who touch all the female body. I would like to start from the first one, which is the brain, but also all organs you will see, the skin, the cardiovascular system, the bone, and the urogenital system, they are touched by the menopause because they are all dependent of circulating hormones. Circulating hormones are disappearing, and this brings to important changes. The first point that I would like to discuss with you is who is one of the most sensitive areas is the brain and the nervous system. As you know, the reduction in estrogen level can lead to mood swings, to changes in memory, to brain fog, to problems in focusing, to irritability, insomnia, fatigue, hot flashes and night sweat, increased response to stress and anxiety, and also, as you know, you have a depletion of gonadal steroid, and by that way, also you have lost your adrenal androgens. You have decreased libido, but you can have also depression, decline in cognition, and later on, this can be linked also to the typical fact that women suffer more than men of Alzheimer's disease. Alzheimer's is a disease of humans. Humans have Alzheimer's, but women have 3 times more Alzheimer's than men. In addition to that, I would like to remind you what happened linked to the estrogen depletion in the urogenital system. Certainly, you have the cessation of menstruation, but you have also changes in the structure of the tissue. You have thinning and shrinking of these tissues. You change your pH. You increase the pH level at the level of in the vagina. You have irritation and discomfort during sexual activity, and also increased vulnerability to vaginal and urinary tract infection too, with vaginal dryness leading to vaginal atrophy, and in the other side, the derangement of bladder control of urine. In addition to that one, we have another important changes in the structure of the female body. That we have that estrogen depletion who bring to an acceleration of osteoclast activity, then who stimulate bone resorption, while osteoblast activity are important for the bone formation, they are less active and this is associated to the development of a progressive osteopenia. The progressive osteopenia, who is also dependent from the basis of how much of calcium you had during your adolescence, this we have to remind, but the progressive osteopenia, as we live longer, when we were dying at 50, they have no effect. But living until 80, now in Italy the mean age of the women is 85, and men 79, but women 85. So living over 35 years after the menopause as a mean time, you have to understand that the depletion, the osteopenia, at the end they move to osteoporosis, and then happen that you fracture because you crash down. You crash down because your capacity to move and to take care for a reduced brain control of the muscular system, this is affected, and then this gives an increase in bone fracture. And as you know, bone fracture are associated to mortality in the first year after the bone fracture for the complication. In addition to that one, we have unimportant changes on the heart and cardiovascular system. This is of fundamental importance. If you reflect, cardiovascular system in women is at the maximum of protection when? During pregnancy, when your estradiol concentration are not 100 picogram or 1,000 picogram, but 20, 30,000 picogram per milliliter of blood of estradiol. This makes a huge protection at the vascular level, touching the endothelial cells, and not only the endothelium, but also all the structure. And menopause is associated, on the contrary, by a growing increase of cardiovascular risk associated to the impairment of endothelial function. And in addition to that, what it should be the ideal treatment? The ideal treatment for that one is associated to something who certainly have to target also estrogen receptor, because estrogen receptors are responsible of the majority of the symptoms of the menopause. But as you know, we have the endometrium and we have the breast who are too much sensitive to estrogen. We have to try, when we speak about the endometrium, we have to associate progesterone. If you associate progesterone, progesterone is harmful for the breast at the end of the story, because it's not so much the estrogen in the breast, but they are mostly the progesterone. Then our treatment have to correct what happened in the brain, have to reduce hot flashes and night sweat, have increased mood and energy level, have to bring a cardiovascular protection, but have also to reduce it, not to touch, or eventually to reduce the incidence of natural breast cancer, that have no exposed to any risk for endometrial cancer, they have to protect against osteopenia and osteoporosis, and have no risk for clotting, no risk for stroke, and also no risk for vein thrombosis. Then we need a product who can try to have all this own activity. Then we have, I want to speak about the DT56A, which the name is Femarelle. And what is Femarelle? What is DT58? DT58 comes from specific selection of soy that go through a germination, and then we collect, and then we make a fermentation process to create a large protein compound that acts in the body as a selective estrogen receptor modulator. It's not acting as an estrogen activator, but as a selective estrogen receptor modulator. And there are more than 20 studies published in leading scientific journals, head-to-head study versus hormone therapy, showing similar efficacy on the symptom, a sweet relief within the first months of use, is a product which have already 25 years of market exposure with more or less 17 million months of treatment, which is produced under strict pharmaceutical condition. And I think this is a very important point. Then now, what are the key studies looking to the efficacy of DT56A? First of all, I would like to show you the efficacy of Femarelle as a treatment on vasomotor symptoms, on insomnia, on palpitation, on headache, on joint and muscle pain. You can see here we reach absolutely, after 12 weeks and then in more dark 12 months, absolutely very important results. And these results, when they were compared to a treatment with hormone therapy in comparison to placebo too, you can see that with the Femarelle we have the same efficacy in Copperman score and in the control of hot flashes. This is something also which is very indicative and important. But I would like to show you something even more interesting. That first of all, we have no changes in endometrial thickness, because no changes in endometrial thickness, no changes in TSH concentration, no changes in serum estradiol, and no changes in serum FSH. This, I would like to point your attention on this point. The fact that it's not modifying circulating gonadotropies, this gives us also the possibility to use before the menopause, during the menopausal transition. And because as it's not touching the gonadotropic concentration, it allows the ovary to go on in its own life, but it has some protective effect. Then I think these results are very convenient. Then how it was studied, in addition to a series of experimental studies done at the beginning, when this 17 years of presence, it was studied using a post-marketing menopausal symptom survey. And this included more than 4,000 participants in 10 countries. And then you can see here the country, and it compared the baseline menopausal experience of women to the beneficial effect of Femarelle following 1 month of use. And women tracks her progress, sees the improvement in the symptom with daily diary, and also the physician receive a direct report on the sweetness of the effect. And it is important to see, you see in blue the pre-treatment baseline hot flashes characteristic during the 4 week of evaluation, and you can see here the result after. You can see how this population shift from highly suffering of hot flashes, with high number of hot flashes per day, they shift down, and after 1 month you can see how it's important with the reduction of the number of flashes, even in the high flashes, and the appearance, a growing up appearance of individuals who have reduced flashes, if they have, and also individuals without any flash per day. And this is the numerical reduction of hot flashes in all respondents. You can see the percentage of reduction in comparison to baseline. But when you go to see the highly symptomatic, the severe sufferers, which more than 7 hot flashes per day at baseline, they were the 34%. In this one, the principle was even more active, because they are the individuals who have a greater sensitivity, a greater vulnerability, central vulnerability, where their candy neurons, they are overactive. And at that level, you see that as we have an interesting response. And it's also important to see that the relief of the symptom was not only touching the hot flashes, but you can see here the percentage, the reduction, the improvement in quality of sleep, in quality of life, in night sweats, in headaches, and in joint and muscular pain. This indicates that we are touching the wide spectrum of action. And now I would like to go on and to speak about the preclinical data and that we have done. You will see later on in the regions of the brain who have in charge mood, sleep, libido, and so on. And this was a study that we have done when I was still active and professor in Pisa. It was published in 2009. We have made a study to evaluate the decline in estrogen level who lead to a reduction in the production of key neurosteroids in the brain, such as allopregnanolone and opioids. As you know, women, they have, with the menopause, they have a depletion of circulating allopregnanolone. The depletion of allopregnanolone at peripheral and central level is depending on what? Is depending from a lower potency and a lower expression of 5-alpha reductase activity, which is the enzyme who in the different brain areas and also in the liver is responsible of the transformation of progesterone to allopregnanolone. But another event that we described, I think, with the first paper in 1980 is the reduction of beta-endorphin. We don't know why, but women with the menopause, they have a reduction of circulating beta-endorphin. And circulating beta-endorphin and a reduction also of central beta-endorphin. And then we have evaluated the effect of the Femarelle treatment in animals on the concentration of allopregnanolone and beta-endorphin in this area, which are responsible of, for example, for allopregnanolone in parietal and cortex and in frontal cortex, then in the neocortex, where higher brain function is expressed. We have evaluated in the hippocampus, in the hypothalamus, in the arterial pituitary, and in serum. And for beta-endorphin, we have evaluated in the hippocampus, which is the archicortex, where cognition and memory are elaborated, and also in hypothalamus, in neurointermediate lobe and the anterior pituitary, who regulate the physiological response to emotions, including the release of stress and mood-related hormone like cortisol and endorphin in that area, and also in the anterior pituitary, who control the general homeostasis, who have the pain control responsibility by the production of beta-endorphin, and which also are responsible of the autonomic nervous system, integrated neuroendocrine function. And these are the figure of the result. It's very easy. This is allopregnanolone concentration in the different areas, frontal cortex, hippocampus, parietal cortex, hypothalamus, and anterior pituitary, in fertile animal, in castrated animal, and castrated animal treated with estradiol valerate at pharmacological doses or treated with growing doses of Femarelle. You can see that as well in frontal cortex, in the hippocampus, in any area, estradiol castration reduces the concentration of allopregnanolone everywhere, and estradiol is able to restore that function, but also Femarelle have a dose-related effect at all levels, increasing the production of allopregnanolone. And that certainly Femarelle cannot be transformed into allopregnanolone, it's completely something different. But this means that it's acting in the same center where endogenous estradiol is expected to have detection. And it was very interesting also to see that one with beta-endorphin. You know, this is the effect of castration, that at all levels in the cortex, in the hippocampus, in the parietal cortex, in the hypothalamus, and anterior pituitary reduces beta-endorphin concentration, estradiol restore, and Femarelle growing dosage, they have a dose-related effect which go in the same line. Then this is something, you know, we were when we have seen the data with estradiol, this was the way how we were thinking that estradiol is responsible to maintain central neurosteroid concentration and central opioid concentration depleted by the menopause. But with Femarelle, you can achieve the same result. And then I think that the summary on brain-derived edema is that Femarelle evidence an estrogen-like activity in the brain, decreases menopausal symptoms significantly and in same degree as with menopausal hormone therapy, and not only assists with vasomotor system, but it also improves mood, anxiety, stress, sleep, and libido. And the effect of Femarelle is felt within the first months of use and assists from mild to severe sufferers, whether they are in their natural transition or following surgical menopause. Then we have a huge series of clinical and preclinical bone build-up, because also the effect on the bone are fundamental. You know, we have to make a protection of the bone. This is something which has to be associated to protect the women to develop from osteopenia, osteoporosis, and from osteoporosis to go and to have risk in fracture. As you can see here, this is the effect on the bone. This is the effect that we have on bone mass density. You know, you can see here the effect of the therapy in comparison to the placebo, absolutely significant. And when you go to analyze where it is acting, it increases creatine kinase specific activity, DNA synthesis, and alkaline phosphatase activity, which are all effects showing that it is acting more through the osteoblast activation than to the osteoclast inhibition. And then we have also another very important series of studies, because it's an estrogenic substance, then it's an estrogenic substance, but the significance, the biological effect, and the sensitivity of the tissue to this kind of SERM, or phytoSERM, can be different. In fact, when you go to the breast, you can see here, this is the effect of estradiol, the effect of estradiol. This is the effect of Femarelle. This is anadoses who correspond to 66,000 times the dose administered in the treatment. And this is the dose administered with the treatment. Absolutely minimal effect in comparison to what estrogen are doing. Because, and the other side, this is the effect at the level of the vaginal atrophy. You know, in a series of women, this was a study where we examined 12 postmenopausal women with severe vaginal atrophy. We have 100% parabasal cell on cervical cytology. They suffer with a lot of symptoms, and you can see here the results. This is the reduction of vaginal pH following 12 weeks of Femarelle treatment. We have a very significant reduction. You can see here after 4 weeks, 8 weeks, 12 weeks. Then there is a typical estrogenic effect on the vagina, and this is associated to the changes between parabasal and to intermediate and to superficial cells after 12 weeks of treatment. You can see the individual the difference in the individual response. Every woman has each one signature in the sensitivity of the system, but at that level we have a positive effect of Femarelle to reverse vaginal atrophy. Then another study, because it's given orally, as you know. Another study was done in clotting. This was a study done by Lila Nachtigal, and she in New York, and she have made a clinical study on which was based on a very particular evaluation by that through that platelet function analyzer. And this is to measure the closure time in seconds and intake from platelets in whole blood, to block the flow through a perforated membrane coated with collagen and epinephrine, or collagen and adenosine diphosphate. And the closure time is a combined measure of platelet adhesion, aggregation, and the blood coagulation factor. Then it examines the capacity to blood to activate the clotting system. And in these 116 postmenopausal symptomatic women, they found one series of them, they were normal one, you can see here, and they were exposed, they were treated either with oral estrogen or transdermal estrogen or Femarelle. Then they had a group of borderline treated with oral estrogen or transdermal estrogen, and they found 7 are normal individual by genetic testing, where they have evaluated specifically the effect of Femarelle. Look, this is the clear, this is nice, and this is nice for those that, as I, who believe that estrogen have to be given through the vena cava and not through the vena porta. They have to be given orally, but you have to give them by transdermal route. And by transdermal route, they don't have effect on clotting. But when they went to evaluate individual with factor V laden, with mutant prothrombin, you know, with condition we are characterized by a strongly thrombophilic situation, you can see that with Femarelle, neither evaluating the adenosine diphosphate test nor with epinephrine, we don't have any activation. Then Femarelle does not affect clotting even in women with thrombophilia. We are contraindicated to take hormones. And then in general, looking the benefit for Femarelle we have the symptom relief similar to hormone therapy, the relief of symptom within the first months of treatment, and targets of neuroendocrine system who answer, and then this is clearly clinically demonstrated by the support in mood, in sleep, and in fatigue. We have a relief of vaginal dryness and a significant elevation of bone mineral density, who is acting through an activation of the osteoblast. And in the other side, we don't have estrogen receptor activation in the breast. We don't have estrogen receptor activator into uterus. Then we don't have any proliferation. We have no effect on clotting, even in thrombophilic women. And we have no changes in hormonal blood profile, and it's not recognized by the body as a real hormone, real estrogen. And these are all the publications that have been done to show these results. In addition to that, which is what is the importance for the state of mind of women and our ability to maintain an healthy aging. You know, the state of mind of women is different. From perimenopause to menopause to postmenopause is something which is who indicate the different adaptation of the adaptation of the individual to different biological situations, who characterize a different individual. Is the same, but is a different individual. And each one of them, they have their needs. You know, in perimenopause, still the woman menstruates, although the cycle is not regular anymore. But we have the symptoms who start to appear and have a major impact on daily life. For this, I think also in general that we have to start our treatment from menopausal transition. We have not to wait the menopause or to wait 6 months in amenorrhea. Quando mai? We have to start early as possible, because the symptoms start to appear and have a major impact on daily life. We have already mood changes, increased anxiety, irritability, fatigue, skin dryness. Most women do not relate symptoms to estrogen decline, and it is crucial to speak to women to prepare them to the upcoming changes. We have to invite the women to come to us during menopausal transition. Later on at menopause, when the period stops, women are aware that they are in menopause. More recognized symptoms by the women, as you know, are the brain symptoms, hot flashes and night sweat, but also the genital symptoms, the vaginal dryness. And however, there are many additional symptoms they experience related to estrogen decline, such as insomnia, fatigue, increased anxiety and irritability, loss of libido. Oh, these ones are all originating in the brain. You know, the brain is the most sensitive organ to the steroid, androgen, progesterone, and androgen depletion too. The loss of libido is the lack of androgen. And later on in postmenopause, she is smiling, but they're not all smiling. When hot flashes diminish, women will state the menopause is over. However, for healthy aging, it is crucial to support the urogenital aging, the sexual health, the vaginal dryness, the genitourinary syndrome of the menopause. You know, now, once the women, they marry with men who normally have 10 to 15 years more, because we marry very young with a man who have to take care of the family. We were working one per family, no more. Now we marry of the same age, or even the women, even of higher age than men. We need, both of us need to work to maintain the family. The situation is completely changed. Then we have to think about that one. And we think about the importance of sexual health and the vaginal dryness, the importance to correct the genitourinary syndrome of the menopause, and recurrent vaginal urinary tract infection. They are touching not only the woman, certainly touching the woman, but are touching all the family, also the husband. You know, how we can see our companion of our life to suffer for that one, and to have the idea that if I approach her, I will make something bad for her. She will have postcoital urinary discomfort or vaginitis. Absolutely unacceptable, unacceptable. And then also, I think that we have to think about that now we live longer, and then osteoporosis is of fundamental importance. The women also, they live longer than men. The widow, they remain widow later on. They remain alone. The family is reduced in number. We have no more 4, 5, 6 children. We have sometimes only one if we have. Rarely we have 2. Then she's living alone. Then it's very important her statics, how their capacity to move inside to the side and to protect the bone and muscle. then depression, insomnia, energy levels and fatigue, and cardiovascular health. For all of this, we have to try to be close to the women. And when they come to our office, we have to start asking with them, since the menopausal transition, to ask and to try to understand if they are already starting that evolution, which is a natural evolution, is normal, it's not a disease, absolutely it's not a disease. But as we live so long after, it's probably better to correct than to wait and to leave them, even though if they are non-symptomatic at all. This is, there are a series of questions that we can offer to them. And we have also to speak with them about how they feel, how they stay during the day, and also about their interest to sexual life, about the possible, the quality of the intercourse, if they are painful or not, if they have recurrent vaginal or urinary tract infection. And then, and then to speak about also the mood changes and also about the existence of night sweat and these changes in sleep quality. This is something which is very, very important for its terrible impact on cardiovascular function, on general health, and also on mostly on the quality of life. Then, dear friends, I am a man of hormone replacement therapy, but in this world, the women, they don't want to do. I don't know. It was our responsibility responsibility of the journal, of the newspaper, of the general information. Some of women, they can't. If they have a breast cancer or an hormonal sensitive cancer, they cannot do. But the majority are afraid. If we see the number, only few are using. Then we have to try to help them also having different approach. And I think that Femarelle can be one of them. While women can live without estrogen, its decline significantly impacts their quality of life and overall health. Femarelle serves as an excellent non-hormonal option for managing symptoms of menopause, providing both short and long-term health benefits. As gynecologists, we have the opportunity to enhance women's well-being by promoting healthy aging and mitigating postmenopausal health concerns. By offering non-hormonal solutions, we can break down barriers, encourage open communication, and remove the reservation many women have about treatment. And by that one, I would like to thank all of you, and I think we have also some time for questions. Thank you, Mrs. Chairman.
Thank you, Andrea. It was very exciting as always. And I would like to ask your first question, actually. Some weeks ago, here in Latvia, our famous investigating journalist, Inga Springer, started to investigate perimenopause. And we have a lot of YouTube videos regarding perimenopause. And famous gynecologists in Riga now have a lot of women who started to say, I am in menopause, please check my hormones, please check my status, what should I do? But how we can start this conversation with these patients? Because it's a flow, it's a big flow of women which are concerned about this situation. And the most important thing is weight gain. You didn't mention it in your presentation, but weight gain in Eastern Europe is real fear.
Yes, no, I agree with you. I think we have, we have to start with women telling them that life will change for you because your personal condition is changing. And as you had in adolescence, you were growing, you became a woman with with a different perception of what you are inside to the society, inside to the world. Then with the menopause, you will have another very important changes, which is associated to the lack of all the factors that were supporting you in your life, in your physical life, but also in your psychological life until now. Then we have to offer a support. We have non-symptomatic women. The non-symptomatic women, they are a minority, but they exist, non-symptomatic. The non-symptomatic, they are less, all studies have shown that they are less vulnerable than the symptomatic one. But for the symptomatic women, and then this one we have to provide an help. I am not in favor to the concept that, okay, it's a natural event, the menopause. You have to wait. Your mother, she had, your great mother, she had. Your mother was living until 90. Okay, you have seen, your mother was living until 90 and she had the menopause. But the impact of life in the other years was different in comparison to now. Now we ask to a woman of 50 to work as a one of 20. Now we ask a woman of 50 to take care of the family, to take care of an official work, a social position, and in a manner which was completely different from the past. And for that one, you need to be as you were. And to be as you were, the hormonal support is the only possible, is the best solution. Is the best solution. You know, John Stevenson knows how the hormonal support is protecting the cardiovascular system. But when you tell, the majority of women, they tell you, no, but I am afraid, I don't want hormones, I would like to make something different. Can you have something? This is the majority, they are telling us. Certainly, a patient who in Italy comes to my consultation, they already know that I am using hormones. Since many I use the estrogen, progesterone, androgen, everything altogether. But the majority, unfortunately for me, they are not coming to me. The majority, they go to their general practitioner who tell them menopause is a natural system, you have to go on, nothing, leave it, otherwise you will have the risk. With Femarelle, we can start another approach. I will give you something which is apparently, no studies have shown any increase in the possible of risk factor. Then you can try with a very safe treatment who is acting in the same system where they are hormone acting, estrogen, not progesterone, estrogen are acting too. I think this can be a beginning, can be a strategy, you know, and we can offer to them. Certainly, if a woman, she wants to have an hormone therapy, absolutely yes, absolutely in favor. We have to make the good one for her. We have mostly to give estrogen by transdermal way. We give progesterone or oral dydrogesterone or progesterone per vagina. And I am also using some androgenic supplementation in those who are touched by the changes in their sexual, in their vision of what they are as sexually oriented individual. Then for hypoactive sexual desire disorder, independently from the desire disorder. But the fact that they lose the pleasure, they lose to intimacy, they lose the pleasure to sexuality, this is touching the family structure. This is touching also the men. With the men also we have a late hypogonadal condition going on with the age. You know, I am 83. When I was 30, 40, I was completely different from 80. This is the nature. But the warming of the females, of the family sexuality is something that we cannot lose when we are at 50s. And also for that one, I am in favor for the hormone therapy. But I found that a treatment such as that one, that we can start during the menopausal transition because it's not touching the gonadotropin, neither the effect of gonadotropin on the brain, nor the effect on the gonadotropin on the ovarian tissue. Then it can be associated starting from that point. We can use later on at the menopause and in postmenopause, and apparently have no contraindication. It's a part of our armamentarium, you know. We have a medicine for each patient, a medicine for each patient. The medicine have to correct the situation, but have to be done in a way that the compliance continue, because most of the individuals, they take a treatment, after 3 months, 4 months, they stop. If you make hormone replacement therapy, you have to follow for years to protect in general your body. But also with that one, we need a different treatment according to the patient. And I think this should be one of our arrow in our arch.
More questions, please? Questions, please?
Yes, one. Gucci from Stockholm in Sweden. Professor Genazzani, thank you very much for your very interesting speech. There might be one thinking, I would be interested in, are there any experiences in using Femarelle in breast cancer survivors?
Thank you. I thank you very much for the question. They don't have done any study on the breast cancer, on individual with active breast cancer or individual who had the breast cancer. And then independently if the in vitro studies, they don't show any effect, I cannot support the concept that can be used in a person who already had a breast cancer. A breast cancer survivor is a breast cancer survivor. We know we need experiment in breast cancer survivor. Without that one, I think it remain it's not an indication, that one. We have to maintain other kind of esters such of SERM, such the treatment with SERM or the treatment with anastrozole. I am against anastrozole therapy, you know. This is against the inhibitor of aromatase, because I found that they have so beautiful effect, which are not so much more than tamoxifen, but they are apparently they are more, but they have terrible effect on the other area, terrible effect on the nerves, on peripheral nerves, on the brain, terrible. The peripheric estrogen depletion means an inhibition of the capacity to produce from the androgen the minute amount of estrogen needed by the other tissues. Certainly this happens also in the breast, but this happens also in other areas. Then, as I am not in favor for aromatase, I found aromatase are a risk treatment for humans. It should be, and the advantages in comparison to tamoxifen, exist, but it is minimal. Now with the early detection of cancer that we have, with the high capacity to identify metastatic tissues also in minute amounts that we can have, it should be, I found better to go with tamoxifen and other kind of treatments needed. But in those who have suffered from a breast cancer, also Femarelle, without specific experiment, cannot be used.
Thank you very much.
Thank you for the question. I'm sorry I was...
Okay, thank you everyone. This session is closed.
Thank you very much, Ineta. And I would like, if you permit, I would like to thank Professor Vasaraudze. You know, she was the person with whom we decided to make this Congress in Riga, in Latvia. And she was strongly supported, and she needs an applause. Thank you, Ineta. Thank you for all the help. It was a fantastic